So I think we've all seen the incredible expansion of telemedicine during the pandemic. I think the tipping point for telemedicine, a lot of us in neurology have been using it for many years for acute telestroke and other selected patient encounters. But the tipping point was really when reimbursement was expanded at the beginning of the pandemic, allowing us all to be conducting more routine outpatient visits with our patients. And it's been a great success during the pandemic. And so for this controversy, the question was, now that we've all been doing it, can we replace our in-person visits with telemedicine? And I'm not quite sure we're there yet. So the concerns or the things that I think about when I wonder if we can just replace our in-person visits is this feasible long-term? And is it available to all of my patients? I want to make sure that I'm giving the same amount of care to everybody. And so unfortunately, right now, we're not sure what's going to happen post-pandemic. So it's feasible currently to be able to give a lot of this care via telemedicine because of the expanded reimbursement, but it's unclear where that's going to go post-pandemic. We don't have long-term assurance that we're going to be able to be reimbursed for these visits. And there's also a significant implementation cost, especially to smaller doctors groups and smaller practices. Those of us in larger academic institutions, a lot of our electronic medical records have been able to kind of turn on the capability to conduct these visits remotely. But that isn't the case for some smaller practices. And during the pandemic, we've been able to waive some of the HIPAA requirements and have been able to use things like Doximity and even FaceTime to conduct some of these visits. But that's not going to be the case long term. So we really need to make sure that we have the infrastructure set up to be able to continue this. The second part of what I consider is availability to my patients. And we've been tracking that a little bit during this past year. And what we've seen are there are continued disparities in care. So I think the hope was that virtual care would expand access to everybody and eliminate some of the disparities in healthcare that we see. But unfortunately, at Wake Forest here, we saw that older patients, male patients, Black patients, and those on government insurance were less likely to be receiving video visits compared to telephone visits. And I think we all acknowledge that there's some difference in the level of care between those two types of visits. So we're not giving the same level of care across all patients right now. I don't think that means that we can't do it, but it means we need to figure out how to do that and improve access to everybody and not just to patients that have access to technology. The only other addition I'll have is the other consideration I think about is not only can we continue providing telemedicine care, but should we? And I think that as we go forward, figuring out which visits are really best implemented virtually versus which visits are conducted in person is going to be the key to figuring out the balance of care going forward.